Thank you, Donna, for that lovely introduction, and also I want to acknowledge the very kind invitation of the organising committee for asking me to come across from Australia to be here with you, and it's been wonderful to visit Vancouver. So what I'm going to do, I guess, is really take you on a bit of a journey in terms of renal supportive care. I'm going to start with some basics and then build up and then talk about both some specifics in terms of symptom management, but also in terms of creating and nurturing a renal supportive care service. So let's start. I'm going to start with a case study. It's a real study. A 53-year-old woman that I met about 2 years ago. Background history of type 2 diabetes, mellitus, hypertension, diabetic nephropathy, and she'd been on hemodialysis for 5 years. She shuffled into the clinic room, her head was down, there was no eye contact. When I started to ask her questions, she said, "My legs move all through the night." She had severe restless leg syndrome for about 2 years. "I itch all the time. Often it becomes ferocious." She had severe uremic pruritus for 3 years. "My feet and calves burn and get pins and needles. It is awful." So she had severe diabetic peripheral neuropathy for 18 months. I asked her about sleep. "I don't sleep. I doze in 5-minute lots. I sit on a chair and put my elbows on my knees to hold them still, and I pray to die." What an extraordinary picture of suffering this is. In palliative care, as a palliative care physician, we are regularly meeting patients who are suffering. But I'd have to say this was one of the most striking cases, or striking situations. This woman really felt that nothing could be done, that all of this was just an horrendous level of suffering that she was going through. So I'll return to her later. We should start with some basics about what is palliative care, but that hopefully that will help us through the rest of this discussion. I guess a threshold question is, what role does palliative care, or a palliative approach indeed, have in nephrology? We'll talk a little bit about withholding and withdrawing from dialysis. We'll talk then about what exactly constitutes a conservative or non-dialytic management of end-stage renal disease. Because if the conversation turns to a situation where conservative care is more appropriate than dialysis, then the first question that's going to be asked by the patient and the family is, well, how are you going to treat me? What is your care going to be? And to me, it's a bowl, and we need to fill the bowl of conservative care to make sure that this is very, very good care. Symptom management, we'll talk on that. We'll also talk a little bit on care of the dying patient with end-stage renal disease. And then finally, we'll talk about creating and nurturing a renal supportive care service. What is palliative care? I put up this image, this beautiful painting, as a metaphor. This is the MacDonnell Ranges in South Australia, a desert country. When European settlers first came to this area, they saw this was God-forsaken, useless country. But it was only through the eyes of great artists like this artist that people started to look upon this territory with the eye of beauty. This is the work by Albert Namatjira, one of our great Aboriginal artists. When these paintings were first shown in the cities, people said the trees could not be that white, the hills that blue, or the terrain that red, and they are. Namatjira had a genius for capturing colour. So I'm using this as a metaphor that we can look upon the geography, the terrain of our patients with end-stage renal disease with two eyes concurrently. It doesn't have to be active therapy or palliative therapy. It's possible to look upon the eyes of our patients with both active and supportive care concurrently. This is the WHO definition of palliative care. I'll let you read that. As you can see, it doesn't mention the word cancer. It's all life-limiting illnesses, including end-stage renal disease. Also, it talks about early identification. One of the great myths about palliative care is it's simply for the dying. Yes, indeed, palliative care does care for the dying, of course, but it's probably going to be a lot better, a lot easier for the patient and the clinicians if a supportive or palliative care approach is brought in a lot earlier in the trajectory of the illness. The other remarkable adverb here is impeccable, so we're setting ourselves a very high standard. And finally, it's more than physical. Of course, it's the psychosocial and spiritual aspects of a patient. And finally, of course, is the family as well. Perhaps that's the formal definition, but I think probably one of the great informal definitions of this area was written by a poet, Bruce Dorr, a couple of years ago. And he wrote a poem called Whitewater Rafting and Palliative Care for my late wife Gloria. If I had understood when down the river you and I went swirling on that boat, that there are those around us who knew the ways of water and how to use the oars to keep afloat, I might have been less deafened by the worry, less stunned by thoughts of what lay up ahead, the rocks, the darkness threatening to capsize daily. If I'd only realised instead that help was all around me for the asking. I never asked, and therefore never knew that such additional comfort could have helped me in turn to be more help in comforting you. I'd have found it easier then to simply hold you instead of bobbing to and fro so much, for it was you who seemed to be more tranquil and I whom death was reaching out to touch. If I'd only had sufficient knowledge in that whitewater rafting, I'd have learned that there are those around us with life jackets to whom I might have in that turmoil turned. Instead, because I had not thought of rivers or rocks or rapids and gave way to fears that seeking help might make a man less manly and liable to betray himself with tears, I was less useful then, as twilight deepened, than I might well have been, had I but known, however wild the waves around us, no one needs to live or die alone. It's wonderful language, isn't it? And it's a great metaphor, the sense of serious illness like end-stage renal disease, where people start to have a conscientious sense of losing control, repeated consultations with doctors, potentially starting on dialysis. I love the fact that in that boat it wasn't just the patient, but her husband, the poet, as well, and how much families are involved. And it's a poem of great regret. Had I but known, you know the ways of water, everyone in this room, and hopefully we can all extend that support to our patients. So there are various myths about palliative care, that there's virtually no common ground for active treatment, that palliative care is simply the care of the dying. Yes, it is, but much more. That palliative care means giving up hope, and I'll talk a little bit about hope later. So the modern view is that there's a wide recognition that these principles should be applied as early as possible in the course of any ultimately fatal illness. The concept of concurrent care, the two eyes on the landscape of our patients. The bringing a palliative approach as the person is dying is a set of missed opportunities. And those missed opportunities are the benefits of early involvement, reinforcing the idea of comfort, that symptom control is impeccable throughout, rapport and trust, demystifying analgesia, and I'll talk a little bit about that, introducing the idea of community palliative care, and help avoiding a sense of abandonment. And the palliative care can be applied to all life-limiting illnesses. So, what possible role does palliative care or supportive care play in end-stage renal disease? I'd say there's probably 5 answers to this. The first is epidemiology. As we know, in developed nations, the characteristics of patients on dialysis have changed over the years. Essentially, there are more elderly patients with more comorbidities. This is the figures from Australia and New Zealand, and these are replicated through most Western countries. While there's been some plateauing in recent times, this is a very stark increase, isn't it? In Western nations, the mean age of commencement on renal replacement therapy is 60 to 65 years, an increasing number of patients returning to dialysis after transplant failure. The age cohort that has the greatest prevalence is the 65 to 84-year-old age group, and that's from the Canadian Organ Replacement Registry report of 2014. Think about that. The age cohort that has the greatest prevalence is this particular age group. And think about what's happening through that time. Retirement, looking after grandchildren, the illness of your spouse, the death of your spouse, lots of other issues, but also other comorbidities that you may be experiencing, particularly musculoskeletal disease. The other aspect of this change is the rising challenge of diabetes. In Canada, the prevalent end-stage renal disease by primary diagnosis, 27% is diabetes, and in other countries it's more. I guess one question is, does everyone who has end-stage renal disease commence dialysis? Now, this is a very interesting question because it raises the possibility that there are a lot of other patients who never see a nephrologist in the first place. So what was done in Australia was a very interesting study where they looked at death certificates where it was mentioned end-stage renal disease, CKD stage 5, etc., etc. Then they married that with the meticulously kept data on patients who had ever had dialysis, and this is what they found. In Australia, for every one patient with end-stage renal disease receiving renal replacement therapy, there was another who'd never received renal replacement therapy. Two questions come out of this. Why? And I guess what was the care of those patients who were not receiving renal replacement therapy? The why probably is very broad. It may have been patient choice or significant comorbidities or really a consultation with the local doctor, the general practitioner, the geriatrician, and it was really a consensus that we don't really need to send you off to see a nephrologist. There are so many other things going on and we don't need to, and really you probably wouldn't tolerate or deal well with dialysis. I guess, but it does raise the question of what is the care of these patients? Mortality is an important aspect here. One of the myths that sometimes can come into this whole discussion is that if you place my father on dialysis, he will be guaranteed to have a normal life expectancy. Unfortunately not. So overall, patients have a reduced life expectancy with or without renal replacement therapy. For patients on dialysis, 15.7% from the core report of 2014. And if you're 75 and above, that figure is 25%. So if you're 75 and above now, starting on dialysis, by the end of 2 years, half of your cohort will have passed away. These are significant mortality figures and correlate really or analogous to many cancers. Symptomatology. Patients with end-stage renal failure have a significant burden related to both disease and other comorbidities. Think about that. Think about the age group of these patients and also particularly diabetes, coronary artery disease, etc. What are the common symptoms associated with end-stage renal disease? Well, we have a couple of studies that are very helpful. This particular study looked across 60 separate studies of prevalence data. 59 of those were on dialysis patients. So essentially, it's the symptoms of patients on dialysis. This group also then looked at those being managed conservatively. And what were their results? I'll let you read those figures. And they go on. So as you can see, a high prevalence of symptoms, also in the one patient having multiple symptoms, and also the interaction of symptoms. Now, this is a good example. Perhaps the first case was a very good example. So at night, if you're trouble with restless legs, and invariably it's worse at night, itch, pain, etc., etc., you're often going to have a very disrupted sleep, which is going to add to daytime somnolence and fatigue. So it's the interaction of those symptoms that can start to cascade. On the other hand, if you can deal with the original symptoms, it may well be that you give a significant sleep dividend to the patient. The patient is now starting to sleep much better. Symptoms are prevalent, they're multiple, they're burdensome. The management are challenging with the altered pharmacokinetics of most medications and renal impairment. Quality of life. What do we know about quality of life? Well, at our hospital in Sydney, we've been doing quality of life surveys roughly once every 1 to 2 years over the last decade. These basically are reproducing what's been happening around the world. These studies, now it's very hard to see the top line, there's a dark line right at the top which is patients without illness, but it's the bottom line, the coloured lines that show the quality of life of dialysis patients. The modality, or sorry, the criteria on my side, on this side, are the physical domains, and the far side are the emotional and mental health domains. And as you can see, a significant issue in terms of physical domains, but also that there hasn't been really much of a shift over that period despite multiple endeavours to try and shift the quality of life. So I think quality of life for patients is a very difficult issue. But what about the quality of dying? How much do we know about that in end-stage renal disease? How much is not only known, but how much is attended to? What is the role of nephrologists, renal nurses in this situation, where the patient may be withdrawing from dialysis or there are other situations where they may be dying? What's actually occurring there? What do we know? Realistically, given issues of manpower, it may not be possible for a palliative care health professional to be present in every renal unit. So in summary, those 5 aspects, I think, tied together, nephrology and palliative medicine. But I guess the issue is there's not enough of us in terms of palliative medicine health professionals. So part of the whole discussion in Australia certainly has been the role then of acquiring core competencies by nephrologists, by renal allied health, renal nurses in this area, having some sense of core competency. So if you were to ask me what are the core competencies of a palliative approach, I would say these are the 4 pillars: good communication, symptom management, psychosocial support, and care of the dying. Let's start with communication. Well, I guess once end-stage renal disease is diagnosed and the eGFR is falling, it's important to examine the various options. And simplistically, which it is, really we need to move towards either looking towards renal replacement therapy or a conservative pathway. Decision-making around dialysis is difficult. I guess one of the topics that's going to come up is, Mrs. Jones, I'm not sure exactly how things are going to go, but let's talk about the issue of survivorship here. Is it possible that you're going to live longer being on dialysis or not, and what does this mean? So this particular group, again the Murtagh group, the same from previously, did a very interesting study where they looked at 75-year-olds who had end-stage renal disease, some of whom went down the line of renal replacement therapy, some of whom went down a conservative pathway, and they followed them, and this is the result. Clearly, the group that had renal replacement therapy had a significant survivorship advantage. However, once you factored in comorbidities, particularly ischemic heart disease, that survivorship graphs, the Kaplan-Meier curves fell. So this was the first of a series of studies that started to indicate, or at least suggest, that in the older, particularly comorbid group, it may be that dialysis does not give a survivorship advantage. And each of the studies have been very consistent. You could critique these studies in terms of the power, but they certainly have been consistent. Look at this next study by Chandra, where they looked at groups who had low comorbidity, renal replacement therapy versus conservative, and high comorbidity. And you could clearly see that those lines were very, very close, weren't you? The other study that I think was an enormously concerning study in terms of the ramifications was this study that came out of the United States. This was dialysis for nursing home patients. So consider that group and thinking about what went on there. As you can see, it was about 3,700 nursing home patients. The multiple comorbidities are listed, but probably very concerning is 22% of these patients had dementia. Why were demented patients being placed on dialysis? I guess that was one of the questions that came out. But also this extraordinary result that seemed to unfold there. So by 12 months, about 70% of those patients had died. And those who had survived, their performance status was very poor. You can see it here in the next slide. So from the commencement of dialysis, an increasing issue of mortality, and for those who are surviving, a poor performance status. So it was those sets of studies that started to really give a lot of misgivings, I think, within the international nephrology community and certainly within the United States there about, is it right for every single person to be placed on dialysis? Do we need to think more carefully through this? If we do need to think, which cohort of patients may we perhaps pause and think, would it be reasonable not to start dialysis? Would it be indeed reasonable to commence a conservative pathway? So this particular, and I feel it's a seminal document, came out in 2010 from the Renal Physicians Association of the United States. And I'll let you read the title. It followed a document that had occurred 10 years before, but in 10 years many of these studies had been published. So recommendation number 6, it is reasonable to consider foregoing, as in withholding or withdrawing dialysis, for those patients who have a very poor prognosis or for whom dialysis cannot be provided safely. So it is saying that a conservative pathway is reasonable. It is not medical abandonment. It is not euthanasia. It's not dereliction of duty. It may well be quite reasonable to consider a conservative pathway. Also, they talked about those whose medical condition precludes the technical process of dialysis because the patient is unable to cooperate, advanced dementia, pulling at their needles, not being able to sit still in a chair, unstable medically. I don't think there'd be too much of a debate about these two. What about this group then? Another life-limiting illness. This is the situation where the person is on dialysis and then has, for instance, metastatic malignancy. In our experience, most patients say, well, look, I'd like to continue on dialysis until I cannot, until the issues of anorexia, cachexia, fatigue are so profound that I'm ready now to stop. So it's really a negotiated discussion. But this is perhaps another very central part of these recommendations. They're saying it is reasonable to consider in those patients who are 75 years and above with 2 or more of the following statistically significant criteria predictive of very poor prognosis. A, the surprise question. The surprise question is, as a clinician, would you be surprised if this patient were to die in the next 6 to 12 months? And if the answer is no, I would not be surprised, then that's been statistically correlated with prognosis. High comorbidity score, very poor performance status, Konoski less than 40, and significant chronic malnutrition. Now, if this recommendation said above 75 years full stop, that would be outrageous ageism, because immediately you'd have an 82-year-old standing in front of you saying, look, I'm perfectly fine. So it's not simply age, it's It's the issue of age with comorbidities, and certainly and these other issues as well. The comorbidities, poor performance status, poor nutrition, those sort of factors, those particular factors then being correlated with poor prognosis. Note the recommendations are saying thou shalt not start dialysis. They're simply saying that it is reasonable to consider to forego dialysis and using some of these criteria. If we're going then to look towards a conservative management, what does it mean to conservatively manage someone with CKD 4 or 5? This may be decided in consultation with a nephrologist, or as that Australian study showed, this patient is never referred to a nephrologist in the first place. What level of care occurs for this group? If this being raised as an option, what does conservative pathway mean? What's its content, and can we make predictions about their course? The challenge is to ensure that this pathway as management is not seen as second best or inadequate, but is thorough, systematic and evidence-based. So in that conversation where the patient or the family is saying, well, if we're not going down dialysis, what are you going to do to the nephrologist? And the nephrologist said, I'm really not sure what to do. Well, that's going to be a major issue in terms of how the following communication is going to go. If, on the other hand, the nephrologist says, these are the things we're going to do, this is the content of the bowl of conservative management, it's going to be a hugely different story in terms of the support and the care, the ongoing compassion for that patient and their family. So if you were to ask me, so I'll just come back here, if you were to ask me what is in that bowl, let's talk about that. I would argue it's a combination of all of this. Excellent renal medicine in terms of all the factors that are done in nephrology, but also excellent palliative medicine, the symptom management, psychosocial and care of the dying. It's going to be a combination of both of those. Indeed, this combination also can be applied to patients on dialysis. So again, the 2 eyes on the landscape of our patient. And hopefully, I guess the dream is, as time goes on, particularly with the training of renal registrars and trainees, that they can be adept at both sides of this equation here, both in terms of managing anemia, fluid balance, electrolyte calcium phosphate, but also the management of uremic pruritus, also the care of the dying. So it's a seamless approach across both. There is a modest but growing body of literature, of research on this cohort of patients. This is a very interesting study out of England which talked about patients who are being managed conservatively. The mean age there was 81, and they looked at three endpoints here: symptoms, palliative needs, and functional status. So this is CKD5, conservatively managed, what happened to them? Well, in terms of functional status, this was very interesting. Their Konoski hovered between 60 and 70 for periods that perhaps were longer than most people expect. And certainly in my experience, this is very much the case. And then at around about 2 months before death, they took to their chair. They started to lie down more. Their functional status was poorer. Also, in terms of symptom distress, about 2 months before death, that increased as well. And also, 2 months before death, the palliative care needs started to increase. So this perhaps may start to answer this question. At what point in a CKD5 patient being managed conservatively would you bring in the mainstream palliative care service? Arguably, they don't need to be involved in this period, the period leading up to it. Arguably, that ought to be in the hands of, well, I guess the nephrologist who's seeing the patient, the general practitioner, the geriatrician, etc., etc. But certainly where it's clear that things are now changing, and there seems to be, at least from this study, a clear change in terms of symptomatology and palliative care needs. At that point, you might bring in the palliative care, community palliative care service. And part of that is manpower, of course, as well. What about symptom management? Well, as we talked about, these are those figures, and you can recall those. Symptom control is challenging. Symptoms interact and compound with each other. And remember the connections I talked about, those symptoms at night, insomnia and fatigue. Symptoms may derive from comorbidities, and certainly in Australia, the figures of comorbidities, particularly coronary artery disease, peripheral vascular disease, are very striking. End-stage renal disease constrains the use of medications, so often there's a degree of nervousness about using medications. The pharmacology in the context of CKD is complex. There are multiple gaps in knowledge. Recommendations and published data occasionally conflict on the specific doses of medications to be used, so that does make it hard. But in terms of symptom management, there are probably three principles. Think of the cause, coming back to the cause, being meticulous, but also the principle of non-abandonment. Never saying to a patient, I'm sorry, there's nothing we can do for this symptom, because there's usually something more we can do. So if we're flummoxed, then referring to someone who can deal with those symptoms or continuing to read the literature. Pain. Sarah Davidson, who's from Canada, a nephrologist from Canada, studied 69 dialysis patients. About 62% stated that pain interfered with their ability to participate and enjoy recreational activities. About half said that pain was causing them extreme suffering. And look at this figure. 41% stated that pain was such that it caused them to consider ceasing dialysis. This is an urgent issue. All of this is urgent in terms of dealing with symptoms, but pain can be very difficult. And there's a positive correlation with depression. Okay, let's now talk about the causes of pain. I guess the causes of pain are disease-related: polycystic kidney disease, renal bone disease, amyloid, and calciphylaxis. If anyone has needed to care for a patient, you know how horrendous the pain of calciphylaxis can be. It can be related to the dialysis itself: abdominal pain, peritonism, the Steele syndrome, and cramps as well. But also comorbidities. And again, come back to the age group of often of these patients: osteoarthritis, diabetic neuropathy, peripheral vascular disease, ischemic heart disease, etc., etc. So pain is a very large topic here and multiple causes. I think there's a pain etiquette when we sit with patients, inquiring regularly, responding compassionately, treating competently, and if we're not able to deal with the pain, then referring wisely, not to dismiss or to devalue the pain of someone. That's an extremely important thing. Patients are looking to us for our kindness, our compassion, and our competency, not dismissing symptoms. So principles of pain management: inquiring, treating the underlying cause, being meticulous, being proportionate, and constantly reassessing. So in terms of, if you were to say step one as in mild pain, then acetaminophen, or paracetamol as we call it in Australia, would be entirely fine. It's quite safe in renal disease. It's considered the non-narcotic analgesic of choice for mild to moderate pain in CKD patients, and the dose can be at conventional dosings. If it's starting to be moderate, you may consider this medicine, tramadol. Tramadol is the least problematic, but we need to use with caution and using BD dosings. So about 90% of its metabolites are renally excreted, need for dose adjustment. So if on a dialysis or a conservative pathway with the eGFRs 15 to 30, may commence at 50 BD and maximum 100 milligrams BD. If on a conservative pathway the eGFR is less than 15, then a tramadol of 50 milligrams BD maximum. What about morphine? The difficulty with morphine is this. This is now, we're talking about moderate to severe pain. Morphine is metabolised in the liver into several metabolites, two main metabolites. Those metabolites are excreted in the kidneys. So as night follows day, it's not just may or may not occur, as night follows day, those metabolites are going to accumulate in chronic kidney disease and cause toxicity. So we just need to be very careful, and that's why we tend not to recommend morphine. Now, if morphine is the only strong opioid you have, well, I guess you could use it in very small doses, but very widely spaced apart. We tend to use medicines such as this medicine, oxycodone. Overall consensus is that oxycodone is reasonably safe. In CKD5, on a conservative pathway, we start at very small doses and start to build up. Fentanyl. Fentanyl is a long-acting opioid. It is quite safe to use in end-stage renal disease, and it's not dialysed, so it's got that great advantage. Methadone, again, fecally excreted, so quite safe to use and not dialysed. It has that advantage. The difficulty with methadone, it has an idiosyncratic metabolism, and it's best used by specialists who know how to use it because it has an unusual dosing. Now, one medicine that I haven't mentioned is hydromorphone. Hydromorphone is also metabolised in the liver into hydromorphone 3-glucuronide, renally excreted. It's considered much safer to use than morphine. Again, the authorities talk about using small doses and slowly building up. So if a patient's got moderate to severe pain, you may consider using small doses of those short-acting opioids such as oxycodone or hydromorphone, slowly building up and then moving on to a long-acting opioid at that point. I was the third author on this, and Sarah Davidson and Holly Konicki were the other authors. This was a very comprehensive review of essentially the entire literature on pain and chronic kidney disease, and this was published earlier this year, and I'd recommend that document. Restless leg syndrome. Does it exist? It does exist. I've had one or two patients come to me and told me that the family have told me to behave myself. Stop kicking my legs in front of the television. For goodness sake, what are you doing? What is going on here? It does exist. It's a real syndrome. It's an urge to move the limbs, usually associated with paresthesia, as a feeling in the legs, motor restlessness, symptoms exclusively while at rest, with relief, with movement, and symptoms worse at night. So look at number 3. You're now in bed and you're shuffling your legs, and you have this urge, this need to stand up and walk around. So potentially most of your night could be doing that. The enormous impact on a patient, as it was for the first patient. There are 3 groups in the community that get restless legs. 1, hereditary. It does sometimes come through families. 2, women in the 3rd trimester of pregnancy. And 3, chronic diseases, particularly chronic kidney disease. Its incident, as we saw earlier. Its mechanism is not completely understood. So it's to do, what the theory now is to do with the basal ganglia. The basal ganglia, as you know, famous in terms of Parkinson's disease. This is not Parkinson's disease, it's another disease. But inside the substantia nigra, dopamine is made. Tyrosine is converted by tyrosine hydroxylase to L-DOPA. Dopamine is packaged into vesicles and through to the dopamine 2 receptor. Iron is part of this whole process. Iron is a cofactor of tyrosine hydroxylase. Iron is part of the packaging mechanism into those vesicles, and iron sits in the dopamine 2 receptor. So If you have a defect in the transport of iron here, then it's going to have a major effect. And this is the theory. We do not know why there's an iron transport defect, but it certainly does occur. Also, why is it so circadian here? Why is it mostly worse at night? Well, there's a diurnal rhythm in iron metabolism. Interesting. Also, the substantia nigra is intimately connected in terms of pathways through to the hypothalamus, which has the circadian clock. So that's probably why it's occurring. So the management. This medicine has been used a lot for many years, clonazepam at night. The difficulty with clonazepam, it will often get the patient to sleep, and it may well have an effect on their movement disorder. But the difficulty, it's a long-acting benzodiazepine and can cause people to be very fatigued and drowsy the following day. So the search was on for other medications. These medicines are clearly, there's a good rationale for these medicines, and there's very good efficacy in terms of studies. So basically what you're doing is supplementing the dopamine. We don't use the first group, we use the second group. The first group, the issue there is complications including fibrosis of the cardiac valves. It's the second group that we use, pamprixol or ropinirole, which have been shown to be very useful for restless legs. This medicine as well. Now you may think, well, we surely can't use this medicine because this is going to accumulate in renal failure. It does. So we need to be using very small doses. Does it work? Yes, there are 2 randomised controlled trials showing efficacy for gabapentin in the treatment of restless legs. One placebo, one compared to levodopa. So gabapentin is there. So the doses. So the doses are very, very gentle. There's perhaps no absolute recommendations, but the dosings that we're using are very small. On dialysis, it would be gabapentin 100 milligrams after each dialysis and titrating to effect. Now, this is very small compared to someone with normal renal function, where you'd be moving quickly to 100 milligrams 3 times a day. This is 3 times a week. Okay, so very small doses. If the patient's on a conservative pathway, then we'd use 100 milligrams every second night and titrating to effect. And if it's over 15, gabapentin 100 milligrams knockdown and titrating to effect. We do not wait too long. I'm very interested, perhaps even after the first or second dose, to hear from the patient as to how this is working, because I know that this dose may be too small and we need to start to increase. We also need to be conscious of side effects, so that's another reason we start low and move up gently. Uremic pruritus. What an horrendous symptom this is. It's associated with poor sleep quality, with depression, with quality of life issues and mortality. Now you may ask, why would being itchy reduce your life expectancy? Well, the issue probably is chronic sleep deprivation, cytokine release, cardiovascular issues as well. So this is a major issue. Before I go further, one of the things that's very important to note is that not everyone with end-stage renal failure who is itching has uremic pruritus. Twice we've been caught in the clinic, the patient had scabies or another reason for their itch. So always remember the principle of looking at the cause, thinking. Is this uremic pruritus, or this may be another cause as well? So, pathogenesis of pruritus. We don't have an absolute knowledge about this. There's been a quiet revolution in neuroscience literature in the last decade, starting to accumulate knowledge, but we don't have, let alone what is actually causing uremic pruritus. So there's 2 big issues here in terms of the general story of pruritus and then uremic pruritus. But what do we know? Well, of course, we know epidermis and dermis. I love showing this slide to dermatologists. They say, yeah, we get this. But epidermis and dermis. There's a complex neural network within the dermis and nerve fibres entering the epidermis as free nerve endings. So there's a signalling of itch going from the skin through to the brain. It starts with C fibres in the periphery. 5 to 10% of those C fibres are itch sensitive. Now, there was a feeling some time ago that C fibres were all to do with pain, but in fact there's a small group of those fibres that are itch dedicated. For many years, the assumption was all to do with histamine. Of course, that was causing the itch. Except now we found this, which completely changes that view. And uremic pruritus almost certainly is histamine insensitive. It's histamine independent, in other words. So there's a couple of myths that all itch is histamine related. And the second myth is this. So the pathogenesis of uremic pruritus. I'm not going to go through in detail, but essentially many theories are posed. One, xerosis or dry skin. Dry skin is an association but not a cause, and certainly giving moisturisers can be very helpful. The next thought is inadequacy of dialysis. No, these studies, there's been several studies looking at that, and that seems to be, that's probably not the case. Hyperparathyroidism. Well, hyperparathyroid hormone is not prurigenic, and there's no clear association. Calcium. Again, no inconsistent findings. Phosphate, again, inconsistent findings. The product of those two divalent ions, again, inconsistent findings. So we really don't know. Multiple theories, conflicting findings. So this particular quote, despite this vast array of possible explanations, none consistently have been demonstrated to be the underlying cause, and we need more studies to work on this. So, in the absence of knowledge of what causes, there's inevitably a lot of therapies being described. So what do we need to do, of course, is look at the highest level of evidence. And perhaps they fall into three modalities: oral medications, topical preparations, and ultraviolet B therapy. So oral medications. Our friend returns. Gabapentin. Does gabapentin work here? It does. There are 3 randomised controlled trials, double-blinded placebo-controlled trials showing that gabapentin has significant efficacy in treating uremic pruritus. This immediately raises, as it will to you now in the audience, the interesting prospect of using one medicine for several symptoms. The same dosing, of course. Evening primrose oil. Now, why might evening primrose oil work here? Well, its active constituent is GABA-linolenic acid. The theory is, in the essential fatty acids within the epidermis, there's a normal cascade going from the top down to the bottom. Now, what happens is that the theory is that there's a deficit in a uremic state, a deficit in the early parts of this cascade, and there's a rushing down to arachidonic acid. Now, arachidonic acid then side produces some highly inflammatory, highly pruritogenic substances. Leukotriene B4 is highly pruritogenic. So by giving GABA-linolenic acid, you're supplementing early parts of this cascade, and DGLA co-produces some anti-inflammatory, anti-pruritogenic substances. That's the theory behind its efficacy. So supplementing the GABA-linolenic acid has an anti-inflammatory, anti-itch effect. And so the dosings are 100 milligrams BD, and that would be 2 capsules. I looked at your local evening primrose oil. It's about 50 milligrams each. So it's 2 capsules BD. There's 2 RCTs showing good evidence or good statistical evidence for this, both oral and topical, but we often use oral, of course. Thalidomide, for obvious reasons, extremely difficult to get hold of, but there's a good randomised controlled trial showing efficacy for thalidomide as well. What about the others? Well, really, they don't add up. They don't stack up here. They're antihistamines, probably not. Ondansetron, cimetidine, naltrexone. Look, the evidence is not strong for those, and so while there's been waves of enthusiasm about each, perhaps we just have come down to a couple of medicines. Topical preparations. Well, I suppose the first thing is to so I'll just come back to topical prep. The first thing is to moisten the skin. So moisturising the skin can be very useful. Also, you could potentially use capsaicin cream. The difficulty, it has a transient burning feeling in the skin and often is not tolerated. Ultraviolet B therapy has good efficacy for uremic pruritus. You need a dermatologist, of course, and machines to use it. So I guess it's coming down to a couple of medicines that we're using a lot. We tend to go straight to gabapentin or pregabalin, either of those medicines, and particularly if the patient also has concurrently restless sleep syndrome or diabetic peripheral neuropathy. Then we may, if there's gabapentin resistance, or if it's simply uremic pruritus, we may go to evening primrose oil. But we move pretty quickly on this. We're not waiting for any length of time because we want to try and control these symptoms as quickly as possible. So one of the, Dr. Stain, who's with you in Vancouver now, he was working with us in Sydney, and we looked at this particular study, or Hassan was the first author on this, looking at the safety of gabapentin and uremic pruritus and restless legs in patients conservatively managed. So we found that of all CKD patients on a conservative pathway presented to the renal supportive care clinic with uremic pruritus, 47% reported severity as severe to overwhelming. So what we did then is institute gabapentin, and this was the result. By Clinic 4, median about 12.6 weeks, about 85% reported nil to slight pruritus, and no patients reported severe or overwhelming severity. There were issues in terms of side effects, so again, we need to be very careful with the dosing and starting very small dosing and moving up. But I think if you're careful with the dosing, it can be very efficacious. What about Our Lady at the beginning? Remember her, who was so incredibly troubled by all those symptoms? So what I said to her is, I think we are going to be able to treat you. No, doctor, you can't treat me. Nothing can be done for me. What are you on? She was on a moisturiser. She was on, I think, basic analgesia, but very little. I said, I think what I'm going to do is start one medicine, and I think it's going to help you. And she said, well, that doesn't make any sense. One medicine for everything I've got. I said, well, I think it will. We also started a very small dose of fentanyl patch, mainly because there had been an issue with compliance, and I was a bit worried about using hydromorphone for her. But she was opioid naive, and I said, look, if this causes any issue, take the patch off because I don't want you to be troubled. And that's what happened. But she kept going with the gabapentin, and we started at gabapentin 200 milligrams after dialysis. Why? Because she was 52 years old and not 82, so she was so much younger than most of my patients, and also because her symptoms were so incredibly severe. So we started gabapentin, we started 200 milligrams at the completion of each dialysis, and then about 9 days later I rang through to that dialysis unit. And the next time I saw her, she was a completely changed person. Eye contact, giving her husband cheek, giving me cheek. full of life. And a remarkable story there. Now, I reflected, had I met her 2 years prior, I would have been flummoxed. I would have not known what to do. But it was with time and reading and a lot of patient experience that you start to acquire some confidence there. Let's talk about the care of the dying patient with end-stage renal disease. Well, patients may die, as we've talked about, having been on dialysis or never having been on dialysis. Patients may die in many different ways. The family's view of the manner of dying and the care given will have a major effect on their bereavement and will echo down the years in the way they view death. Everything we do. And the longer I've been working in palliative care, the more I realise in the whole of palliative care that the work we do leading up to the death is also the preparation for the bereavement. If the death was difficult, agonising, chaotic, undignified, that will be remembered forever. If, on the other hand, the death was dignified, a clear, conscientious attempt to deal with symptoms, comfortable and loving, that will be remembered. So everything we do has an echo for our families, for the families of our patients. It may be a sudden sentinel event, like a major cardiovascular event or a major stroke, where the patient has a sudden death. And sudden death can be, for anyone who's gone through that experience for a relative, is catastrophic, of course. And it may be catastrophic not only for the family, but also for your colleagues, for the other dialysis patients, to see that person's no longer coming in, for the dialysis nurses. Everyone feels that. Everyone feels that. It may be a negotiated withdrawal, and that's the situation where the patient is becoming, say with metastatic malignancy, starting to dement, starting to just say, look, I can't keep going on with this. Things are becoming more and more difficult. The sit-down discussion about withdrawal. So look at this particular case. George has been on dialysis for 6 months, increasingly fatigued and more frail, no clear reversible cause. He's further exacerbations of his chronic airways limitation. He's now had a non-STEMI. He presents with a gangrenous toe, post-amputation, worsening gangrene, discussion about further surgery. So I guess there's many responses here, but have a look at these two responses. The first nephrologist. it's time to talk to him and his family about the future. We need to be honest. It is right to say to him that he could withdraw from dialysis at any time. That would be okay. We would then speak about what to expect from that point onwards, including our care for he and his family. So that's one response. Have a look at the second response. They're very different responses, aren't they? The first response is saying things are changing quite rapidly here. And at least perhaps we need now to have this discussion, including the possibility of withdrawal. And if we're going to talk about withdrawal, what we are going to do, because that's the first question they're going to ask, is if we stop, will we be still seeing you? What will you do for me? How will my time be through that time? And this is another response. It's important, I think, that any discussion about withdrawal is open and honest, at the patient's own pace, and includes the family. Let's look at this. Open and honest. A clear discussion about what's actually occurring and what's likely, but if not certain, to occur from this point onwards. A sense of the clinician coming with their enormous expertise and experience to the bedside of the patient with clear language talking through this. At the patient's own pace. It may be on this day that only half of this is really even countenanced. The daughter or the son saying, please don't bring this up, it's too difficult. The patient saying, I need to think through this. I need to really go back to my family and work through this. And also includes the family. So probably the best results are when the family are included in this discussion. Open and honest, at the patient's own pace, and including the family. The questions that come up are, what should I expect if I withdraw? Will I suffer? Will I drown in fluids? How long will I live? These are very common questions, aren't they? The how long will I live is an interesting question. It seems to be that there may be two cohorts here. If the patient is completely anuric, the mean survival is about 7 to 10 days. But if the patient's still passing urine, it may be weeks or months. Now, the latter can be very unexpected, can't it? Particularly if the patient's told that we've only got a week to go and now it's 6 weeks or 8 weeks on. And I spoke to a group there the other night and gave this story, a true story of a man who was 82. He said he'd had enough. He was going to stop his dialysis. His wife then stopped all her activities to come home. They had a farewell really party where he gathered all his friends and family about day 5. 2 weeks later, he's perfectly fine. 4 weeks later, he's still going very well. At about the 6-week mark, his wife said, look, I love you dearly, but I'd love to perhaps go back to my normal activities. At week 12, his friend came and said, Joe, it may be a little bit late to start a hobby, but you need to do something here. At week 14, he was missing terribly his friends on dialysis, so he went back and sat with them. And then at week, I think, 16, 17, he recommenced dialysis. So just to be aware that, and he was told that it was all going to happen very soon, and of course, yes. What about hope? Because this will be the question that's also raised. Are we moving from the land of hope into the land of hopelessness with this whole conversation of withdrawal? Hope is extremely important to us as human beings, but it's now resetting the focus of care. I agree that there's no hope for cure, of course, but there is hope in the following, that you'll be comfortable and supported throughout. The hope that you will not be abandoned, that you will always be listened to, that all your symptoms will be treated to the best of our ability, that you will not needlessly suffer, and that you will be treated with respect and dignity at all times. Patients yearn to hear this, the sense of what this is going to be from this point onwards. Junior doctors have said to me, isn't this implicit in us? Yes, it's implicit, but it's very good to be explicit and say it. Note that we're not saying that you won't suffer, but we're going to do our very best to deal with this in our own way and making sure that you won't needlessly suffer. What about the crisis withdrawal? And I guess this is an important issue here. And this is the situation where someone is on dialysis and suddenly they have a major heart attack and a cardiogenic shock, or a major intractable sepsis, or a major cerebral event. They almost certainly, if it's that major, may well be dying not because of their underlying kidney disease, but because of these other issues. So this is the situation. There is two scenarios here. The major sentinel event occurs And there's a sit-down discussion with the family to prepare them for the possibility that the person is going to die. Also, there's a discussion about where it's right now for us to cease dialysis, and a consensus that there won't be an escalation to ICU. But occasionally this can occur. The sentinel event occurs, there's no discussion about withdrawal, there's a waiting approach, and the patient either dies on dialysis or the day of dialysis. So we went through for the year 2010 what occurred to patients after crisis withdrawals, and it was fascinating to see. You could almost read in those notes the crossing of the fingers. Maybe if we just give this a day or two, the patient may pick up, but we don't really need to get palliative care involved. We don't need to really, we don't need to have this discussion just yet. And so how difficult it was. But could you imagine, and we haven't studied this, those two families, sets of families, the one where there was a frank discussion about the likelihood of imminent death and the involvement of palliative care versus the ones who did not, and how they would remember that period. This scenario is considerably assisted if the patient has had a prior conversation with the nephrologist, including an advanced care plan. An advanced care plan is a message to the future. I, as a competent patient now, wish to say my views on what should or shouldn't happen to me later, my wishes for the future. And really, advanced care plan is triggered in terms of looking at it when the patient is incompetent. So if it's never been discussed, that's one thing. But if at that conversation the discussion has occurred and a conscientious attempt has been to nominate a surrogate decision maker and also to talk through what you may or may not wish at this point, including withdrawal from dialysis, that would help a lot. Okay, creating and nurturing a renal palliative care service. Well, first of all, we needed to meet with each other. It's like a school dance. Renal medicine and palliative medicine needed to sit and talk with each other. So some years ago, there was an overture from the professor, the head of department, Professor Mark Brown, to us, to speak to us. And so he said, look, we're really troubled. We've got an increasing number of older comorbid patients coming onto dialysis. We're not sure whether this is the right thing. We've done a symptom inventory, just a short. We're appalled at the number of symptoms, and we're not good at caring for the dying, so we do need your help. So there was a formation after some discussion of a renal supportive care clinic in March 2009. It's held every week. It's now we've got it twice a week. It's held in the renal unit, so it's familiar territory for the patient. It's myself as a palliative care consultant. The advanced trainee in renal medicine is mandated to come. It's not I'd like to come or not to come. This is part of your training, so this has been extremely useful, particularly for those junior doctors who've never had any exposure to palliative care before, a clinical nurse specialist and renal social worker. We also have available renal dietitian and renal social worker, as I said. All patients with end-stage renal disease according to need, so everyone can come. So it's not simply a conservative clinic, it's for everyone. So that would be patients who are on a conservative pathway, yes, patients who need assistance in decision-making, patients who are on dialysis, who have cancer, patients who have dialysis for symptoms, patients who are dialysis who need assistance regarding withdrawing, or basically those sort of very broad discussions. There's a focus on symptom management, psychosocial support, preliminary discussions regarding advanced care planning, and access, as I said, to social work and dietitian. We use this particular symptom inventory. It's probably too hard for all of you to see. It's a one-page validated symptom inventory tool, validated for renal patients. It's 17 separate symptoms. It's an extremely efficient story because we talked earlier today about time management. In clinics, the patient, the relatives or the nurse, and with the nurse will fill this out. So when the patient walks in, I can then go to the ones that are the symptoms that are moderate to overwhelming and not be troubled by the symptoms that are not present at all. And what we do it for every patient at every clinic, so we're able to follow the group through. Sorry, I should have named it. It's called the POS-S Renal, the POS-S Renal. We also have a teaching program for junior medical staff, including nephrology trainees, on all aspects of renal supportive care. So for the first time in Australia, in a renal department, as well as discussions on all aspects of renal medicine, there is now a component for all doctors on renal supportive care. We're preparing documents, end-of-life pathway for renal patients, commonly used palliative medicines, and what we've called a renal palliative care reader, which is basically, and I'll be very happy if people are interested in getting copies of this, the best of the best articles, review articles in this area, recommended reading lists and extended bibliography. We also have an annual renal memorial service, and what happens there is that our social worker sends out letters to all relatives of patients who've died in the last couple of years, and then we have a non-denominational gathering. I'd have to say it's very cathartic, it's very wonderful for the renal nurses, particularly those who've known those patients for many years. We have nephrologists, renal nurses, patients, relatives reading out beautiful pieces, poems, some music, and it's a very, very good way of perhaps commemorating your loved one. We also have had, from 2010 onwards, an annual renal palliative care symposium where we get people from around Australia and New Zealand together and go through this area. We've also developed, or in the midst of developing, a renal supportive care curricula, and the aim will be to eventually have, in multiple centres in Australia and New Zealand, masterclasses for trainees, not just in renal medicine, but palliative medicine, geriatric medicine and general practice, because really it's those four groups that are going to be attending to these patients. What are the best books and materials in this area? And this is very important that you read deeply, I think, because this will help a lot. Probably the highlight is the second edition. It's the second edition you should go to of supportive care for the renal patient, with the best authorities in the world who've written in that. There's also an Oxford textbook, Oxford Handbook from Advanced Disease to Bereavement. The second edition was published in 2012. There's also that document that I've spoken about before. In Australia and New Zealand, we've now published a renal supportive care position statement with multiple contributions from nephrology, palliative care, ethics, the law. A professor of law has written on the law, cultural dimensions in terms of particularly our Aboriginal and Maori communities in the two countries, and the multiple religious perspectives on this as well. So that would be a good document to have a look at as well. I'm very much aware of your end-of-life care framework, recommendations for the provincial, and I applaud the work that is being done here in British Columbia. So in conclusion, I think it starts with a mutual acknowledgement of need, the role of palliative care, supportive care in end-stage renal disease. The last decade has seen considerable levels of advocacy, attitudinal shift, research, publications and collaboration. The approach may come at multiple points in the trajectory of the illness. The core competencies in a palliative approach can and should be acquired by all doctors working with these patients. It applies to patients who are being managed either with dialysis or conservatively. The family will remember forever your involvement, your demeanour and your compassion. And remember, your patients remain your patients until their death. Thank you.
That was truly an amazing presentation, and I'm very, very grateful that Dr. Brennan was able to travel today to be with us. One of the downsides of being a chair is that you do need to be mindful of time. So we are right on target for time, but what I think we could do is maybe go for 5 minutes of questions if there are some. So it looks like Dr. Connolly, did you have a question?
On all of these checklists, we always ask them about their energy and tiredness, and it's always off the chart, right? What do you say to that, and are you using any of the new things like Ritalin or any of that kind of thing to address that?
Can you hear me? Yeah, it's a really good question, because fatigue always tops the prevalence list, doesn't it, in every study. Fatigue is such a debilitating symptom, and I find particularly for patients who used to being very, very independent, very active, and now I'm becoming more and more fatigued. A couple of things. I certainly say, I try and normalise it. I say, look, that every patient who comes through this door is feeling fatigued. It may be that this fatigue is going to change a little bit. It may be there are certain days when you're going to feel a little bit better. I guess a couple of things in terms of the reversible causes. Now, of course, we need to be very conscious of the haemoglobin, to making sure that the haemoglobin is in the right level. And of course, I rely on the nephrologist to be attending to that. Also, there can be other causes such as electrolyte imbalances, hyperkalemia, calcemia, hypomagnesemia, etc., looking at that. Then also, I'm also intrigued, and a couple of times I've come across this, where the main reason for the fatigue is, the patient who's, say, in their mid to late 80s, I've got a lot of arthritis, I sit most of the day, I don't really want to move around too much, basically deconditioning and fatigue. So trying then to deal with the pain of the arthritis. The whole thing, so normalising it, talking, and then also some basic things. Some simple exercise, some upper limb exercises have been shown to be useful, and also just gentle walking, just doing some gentle exercise can be very useful. I haven't, and I'm aware that yes, certainly in terms of cancer-related fatigue, the use of psychostimulants like Ritalin is sometimes used. I haven't yet used it in a chronic kidney disease patient, and I suppose the time will come when I may, and that's probably going to be a situation where the person is ferociously upset by this fatigue and who just wants a little bit more energy, and potentially you might use that medicine. But often it's really normalising, talking through things, gentle exercise, and then dealing with symptoms. The other aspect of fatigue, of course, is how is your sleep? And if the answer is, I don't sleep, or my sleep is poor, what's causing that? And you go back and you look upstream to what's actually disturbing sleep. And it can be that it's the first time that forever that they've talked about restless legs. So it's really unpacking the entire story. But thank you for that question.
Sarb?
Oh, thank you, Dr. Brennan. It was a wonderful presentation. And it's good to also see that in BC we're trying to follow some of those great ideas. One of the things that I'm curious about is I work in a CKD clinic where we see a lot of patients who are preparing for their transitions. And for those people that may be considering conservative care, but they're ambivalent due to various reasons, that they may want to trial dialysis and see how things go. Some of them may do okay, some of them may not do that well. I'm wondering if in your program, if there's any established pathways to follow those patients a little bit closer?
This is a very good question, isn't it? This ambivalence and the weighing up, particularly for some patients and some families, where you may have the patient somewhat reluctant, but the family is saying, please, Dad, we can't let you go, or we want you to start on dialysis. So yes, the concept of a trial of dialysis is known, of course. It actually is included in that Renal Physicians Association document in the United States, where they talked about that being a perfectly legitimate way of dealing with this. The only difficulty is this: the psychology of this. While there's no medical, legal or ethical difference between not starting and stopping, because if both the law and ethics say if the treatment is too burdensome, it's okay to stop. There can be quite a profound psychological difference between I've never started versus I'm now 3 months down the track and I'm on this and I may then stop. I can't, because I'm not a nephrologist, I can't speak on behalf of the nephrology community, but I think certainly Professor Brown, who's head of department, he is troubled by trials because of this very issue, because of then the whole thing of then having to go through or discussing the cessation, where there can be quite a degree of difference of opinion as to whether Dad is going okay or not okay, and how things are going to go, versus up front having that discussion and not starting in the first place. It is legitimate, of course it's legitimate, but it does have that extra psychological issue. Look, we've been going on, and why would we stop now, and surely we can keep going. So there's that extra dimension there, isn't there?
So in the interest of time, this will need to be the last question. So microphone 3, please.
Hi, sorry, that was really loud. I'm just wondering, the collaborative meeting that you have, or clinics that you hold between the renal medical team and the palliative team, are those group meetings, group attendance, or are they individual patient-centered? I may have missed that point when you were discussing it. I was just wondering.
Yes, no, sorry, I probably went through that too quickly. So the beginning meetings, as in when we first met, the school dance, if you like, was yes, around the table. So it was senior renal nurses, I think one nephrologist, and palliative care, myself, and just sitting and talking through, getting to know each other, getting to know the dynamics of things. Then when we got to the point where we set up the clinic, so we then had the clinic, and the clinic is for individual patients to come, time.
Okay.
And those patients would be either dialysis or conservative. And in that clinic, there would be myself as a palliative care consultant, a renal supportive care nurse. In fact, she's the first Australian appointed full-time renal supportive care nurse, etc. There are other models. Another model would be that it's in fact run by the nephrology team with palliative care input. Or in Christchurch in New Zealand, they have a fascinating model where in their clinics that they hold every, I think, 2 to 4 weeks, in their clinics they have, in a renal supportive care clinic, they have a nephrologist and a palliative care specialist and their trainees swapped. Isn't that interesting?
That is interesting.
So the trainees are under the other consultant, and so there's lots of different models that you could use. So it could be, I think, it must have the imprimatur of the renal department, and particularly the head of department, of course, that's very important. It may be that you have a nephrologist, you have a palliative care, or a combination of all, but a lot of cross-fertilisation in terms of discussion. Okay, what else can we do here, yeah.